All right, welcome back everybody to the Biochemical Genetics Clinical Core Seminar Series. It's September 20th, 2024. This is week 10 of the series, and we're happy to welcome back Dr. Tim Wood. Dr. Wood is the head of the Biochemical Genetics Laboratory here at Children's Hospital, Colorado. He has been for a few years, and before that, he was at Greenwood running things. And so we're very, very happy to have Dr. Wood and his expertise in the laboratory and biochemical genetics in that context. It's something we don't get to hear about very often, and it's one of the only lectures in this series that addresses this. So very happy to have him back. Just some housekeeping things before Dr. Wood gets started. Next week, we have Dr. Bob Steiner coming to talk about lipid metabolism disorders. The code will be popping up in the chat. Thank you, Sarah. It's Kezrat, Kezrat. So if you want CME credit, send that in to the number or website there. And I think, Dr. Wood, you want this to be relatively interactive, so feel free to unmute and ask questions, put things in the chat, be as interactive as you want to be. So thank you, and without further ado, I'm going to hand it over to you, Tim.
Yeah, thanks. Thanks, Pete. Thanks for those of you that can sign on to listen. This is a sort of a fast pass at the techniques that I think we broadly use in biochemical genetics. Certainly each one of these could be its own lecture or own lecture series. And if your favorite assay wasn't mentioned, it's only because we didn't have a lot of time and probably because I don't have enough expertise. So like Pete said, I'd like this to be interactive. I do want to acknowledge that I really enjoy working in this field, and one of the reasons is the collaborative nature, and that a lot of what I'm going to talk about today, I've had explained to me and sometimes re-explained to me by some very bright people, and too many to acknowledge. But I really appreciate the collaborative nature, and I appreciate Pete for organizing this. Let a little bit of lab seek in, and if there's a specific lab technique or something you'd like to see, I'd put that in the comments, because you're certainly talking about like metabolomics or mitochondrial disorders would be mitochondrial testing would be super cool. Again, as Pete said, if you'll put stuff in the chat or want to unmute and talk, I've got several things in here where I hope we could have a little bit of discussion, and I'll do my best to keep us on time. So the first things I want to make sure that if you haven't heard before, that I'm part of a really dynamic team. That's the SIMD Laboratory Work Group. That's a US Canadian based work group that focuses on laboratory testing for biochemical genetics. It's led by Dr. LePage and Dr. Miller. We meet once a month, and if you want to send them a message if you're interested, or send me, I can get you involved. I know laboratory biochemical genetics, sometimes if you're the only person in your institution, can be a little isolating, and this is a great way to talk with some colleagues and hopefully some future friends about how we do our work. So the history of biochemical genetics really, to me at least, came out of screening for inborn errors of metabolism. A lot of it was done using fairly what we would now call sort of crude assays, but they worked, and they were a lot of times done in urine, and you were looking for a color change or a precipitant or something like this. This is a positive ferric chloride test from a patient with untreated PKU. Starting in the 1950s, 60s, we've had a steady evolution of becoming more precise and being more in line with general analytical chemistry, things like amino acids, the advancements made in urine organic acids, a lot of which was done here in Colorado. Really cool azocarnitine work that I think of as being done at Duke, but I know it was a little broader than that. And then all the kind of functional testing, enzyme testing, and those are kind of the outline of what I'd like to talk about today. So when I first started 25, 30 years ago, biochemical genetic testing was a main part in diagnosis. And a lot of times when you had a clinical suspicion, or you had a patient with, say, a nondescript phenotype like seizures, biochemical testing was what you could get done. It was what put food on a lot of biochemical directors' uh, dinner tables at night, was that you had this broad testing. And so everybody that came into clinic got an amino acid, everybody got an organic acid for relatively low yield, but that's what we could do. If one of that was positive, maybe you sent off some enzyme testing. A lot of times required a fibroblast biopsy, or you couldn't do it in blood. And finally, and this is the part that I know amazes people that are new to the field, there was a time when you couldn't get molecular testing done. We didn't know all the genes, or they weren't clinically available. Molecular diagnostics was in its infancy. And so this was a heyday for biochemical testing, because it was a way to narrow down your diagnostic odyssey for the patients. But of course, now we're in a place where we're in a situation where you have a clinical suspicion, you do exome or genome sequencing, and that makes the diagnosis. And I've had more than one fellow or clinical colleague or clinical teammate that said, yeah, how does biochemical genetics fit into this? Where we just don't need it, because this is the way we're going to test for genetic conditions. And so just to stand up a little bit for my field, for what I love, keep in mind that a lot of times, although rapid genome is fast, a lot of times we can do these quick tests fast. We can do some of these tests a lot faster. And then we can, especially if a treatment is linked to a specific condition, we can get that treatment started. It allows the care teams to coordinate results with clinical visits. On the backside of an NGS analysis, an abnormal analysis might allow you to take a deeper dive or reclassify a variant. And finally, logistically, it's still a requirement for a lot of training programs to have some kind of laboratory aspect to it. So one of the problems that we have with a local lab is we're asked to think about all of these metabolites and all of these conditions. And each one often, a lot of times, has a single test or even a series of tests that has to be done to make the diagnosis. So I always feel bad when our clinical team has to send something out. But at the same time, we can't be an expert in everything. So just keep in mind that from here on out, a lot of what I'm going to talk about in terms of how we do the testing applies to all of these various conditions, even though the examples that I use are limited. So what do we look for in biochemical genetics? Yeah, there's a gene, and for most conditions, and we look for pathogenic variants in that. But biochemical genetics works at a level above that. It works at a functional level. What's going on with the whole organ, the whole cell, the whole organism. And so we can measure enzyme activity if we find that's deficient. A lot of times what'll happen is there'll be a substrate that we can look for that's elevated in blood or urine or CSF. Or what's a little bit harder sometimes is to pick out a product that might be decreased. And so just to point out, a lot of times if we can design a test and we can make it work in normal individuals, meaning we can detect the substrate or the product, it's a little bit easier to detect something that's much, much higher than what we normally see, and sometimes what is a little bit lower. It's just a little bit hard to pick out how things at that very low levels. So how do we decide if it's abnormal? I think this is really important to understand, is that to do that, you've got to run through a lot of normals. And we used to think 100 normals was a lot. Now it's not. You can look at means, plus or minus 2 standard deviations. You can use z-scores. Keep in mind that normal ranges may be age-related, especially anything you do in urine. And if you're right at that age cutoff, we artificially define a lot of times those age-related cutoffs. It's really more of a gradual change as the patient gets older. And what we really need to know is if the normal range and the affected range differ, and how much they differ. And to do that, we need to have a large number of affected patients. And that can be really hard to do for a rare disorder. So just keep in mind that there's a lot of work that goes into designing one of these tests, to developing these age-related ranges, and then to giving you a good clinical interpretation. The other thing that causes problems, at least why I had hair when I started a lot of this, was that there's all kinds of factors outside of just the genetic defect that can influence values. These can be medications, things like valproic acid, vitamins or supplements. Just the time since the last meal can have a great influence, especially of amino acid values. Liver dysfunction, or if the patient is terminally ill, they can look like they have certain genetic conditions, or you can see metabolites that just shouldn't be there. For some specific analytes, the time since blood draw, there are a handful of very time-critical metabolites that have to be processed. The blood sample has to be processed very quickly to stabilize them, things like S-adenosyl homocysteine. A little bit rare, the type of collection tube can make a difference. Where I got bit with this is if you're thinking about doing blood-based gag analyses, don't draw a blood tube that's got heparin in it. That can cause problems with certain of the gag assays. We can see metabolites from gut microbe, and of course, what we come up with is sometimes metabolites of uncertain significance, or a moose, or a, I don't know what you want to call it. I'm still waiting for this to catch on, but there are some times where we see stuff that it's not as high as what we would see in a patient with a genetic condition, and we're not exactly sure when the gene sequencing is normal why we're seeing it in an individual patient. So that's just a little bit of background of what we do and how we think about biochemical genetics. And then what I want to do is spend the rest of the time talking about 4 specific tests. So we're going to talk a little bit about amino acid analysis, organic acid analysis, isocarnitine analysis, a little bit about enzyme or functional analysis. And again, there are all kinds of people that can give great lectures on peroxisomal defects, other type things. I just didn't pick those for this talk. The rationale was that pretty much everybody in our field is going to deal with these 3 to 4 tests at some point. And so we would start here, and then you can branch out from there. When possible, I've tried to include the references with a PubMed ID, or maybe I've even given you a picture of the specific paper. But if there's one that I missed, please let me know. So for amino acid analysis, the rationale is that I got this from the NAMA slide, and which is a wonderful course if you guys get a chance to do it. Mainly sample type we're going to use is going to be plasma or serum, less and less blood spot. These are less commonly blood spots. These are really good for pathway defects, non-transporters, PKU, tyrosinemia. This is going to be our go-to sample type. For certain disorders, and I've listed some of them here, urine is actually optimal, and these are going to be the disorders of amino acid transport. We don't do a lot in CSF, although I think it would be a good sample type for us to explore more, but there are a handful of metabolites that you can detect via CSF. So the sort of historical way that we did this, there we go, was using a kind of a big laundry washing machine type instrument called an amino acid analyzer. And I'm going to tell you a little bit about how that works, and then we'll move on to some of the newer technologies. So when we do this, we take up typically a plasma sample, although it works the same way with urine. We deproteinize it, typically with some acid, and we add an internal standard. And the internal standard is important because we have the same amount of internal standard as we do to our calibrating solutions. and our calibrators. And by knowing the concentration of the various amino acids in the standard, we can then infer the amount of individual amino acids in the patient samples. So historically, this was done by something called ion exchange chromatography, and more recently with UPLC chromatography. For ion exchange chromatography, the separation is based on a series of buffers and changes in those buffers, changing things like pH, salt concentration, and temperature. One of the big things I want to mention here is that retention time is the main way we identify these compounds. So if you have two compounds that have the same retention time, that can be difficult for us to separate. And one of the classic ones here is methionine and homocitrulline. The way we detect these is looking at two wavelengths, 570 and 440. And I already told you how we quantify them using our internal standard and a calibrating solution that we've run previously. So this is what one of these profiles looks like. I want you to keep in mind that on bottom is on the x-axis is time. And so these things can take a little over 2 hours to run if you want a full amino acid profile. And that's one of the real drawbacks to some sort of an anhydrine-based amino acid analyzers, is just how long it takes for one sample to come off the instrument. As we go from left to right, you see we get an individual peak that corresponds to each amino acid. And in this case, we've used an internal standard that comes out here at about 100 minutes. I'm going to show you a couple of others where the internal standard comes out much, much earlier. So this is what a patient profile might look like. Typically, glutamine, glycine, and alanine are some of the most abundant amino acids. Then you get sort of a second tier of amino acids, threonine, serine, and then at the lower end, you see a metabolite like citrulline, which you can see again here. The peak I'm showing you is quite small compared to the others. So what can we use this? What can we use this to diagnose? First of all, we're putting in the same amount of internal standard into all of these, and that allows us again to make a direct comparison. You see elevations in glutamine that can be associated with hyperammonemia. Elevations in alanine can be associated, alanine and proline can be associated with lactic acidosis. You see elevations in methionine and tyrosine, they can be associated with liver dysfunction. So those are some of the common things. And again, we're using this test a lot of times to study infants who are sick and in the hospital. So it's not unusual to see abnormal elevations in patients who don't necessarily have an inborn error of metabolism. But what does a profile look like on a patient with an inborn error? So I showed you where phenylalanine is here. I should have kept the x-axis on. But so this is what a profile would look like on a patient with, I'll let you guys think about it. Here's glutamine, glycine, alanine again. But now we have this big peak over here to the left, and it corresponds to phenylalanine. And so this is a patient who has PKU. And so as you look at these different profiles, I'm not going to show 100 of them to you, but you could see a nice big peak of tyrosine in a patient with tyrosinemia. I will show you a couple of others, but the nuance here is the same. Okay. So here's another patient to look at. I've switched the internal standard over here to the left. Here's our glutamine, glycine, our alanine's a little low in this patient. But what are some of the elevations that you see? And again, you can say it to yourself, you can say it out loud. But what do you think this patient has? Yes. So, had somebody mention MSUD, right? You see the elevations of the branch chain amino acids, valine, isoleucine, and leucine. But the big thing you see is the presence of allo-isoleucine, this nice peak right here at, it looks like right around 70 minutes. And that's what we think of. And I want to come back to this diagnosis a little bit later. So there are certain metabolites that are pathognomonic for the condition, and allo-isoleucine is one. But you can, in patients with ketosis, also see elevations of the branched chain amino acids. And what I typically do is I look very closely at where I should see allo-isoleucine. And if I don't see it, then I think about the patient's probably just ketotic. So the other thing that I've been taught is actually the ratio of valine, isoleucine to leucine is different in ketosis from MSUD. I think about patients with MSUD will have a grossly elevated leucine peak, and valine and isoleucine will typically be lower, whereas in patients with ketosis, a lot of times valine is the most abundant of those three amino acids. And again, in ketosis, you don't see allo-isoleucine. So maybe somebody can put in the chat. I know a lot of people are trained that there's a specific ratio in ketosis or what's normal versus abnormal. I didn't put that on this slide, but maybe somebody can put it in the chat. Okay, what about this patient? Again, here's our internal standard. Here's glutamine, glycine, alanine. In ketosis, glycine also be elevated. I believe that is true. Yes. Yes. It's hard for me. It's hard for me sometimes to, I mean, there's a lot of things depending on how sick the kid is and how much supplements and other things that they can have. There can be lots of things. And of course, they can be ketotic and acidotic. So you can get a spectrum of elevations in a very sick child. All right. So this is a patient with citrullinemia. Nice big citrulline peak. In fact, I've cut it off here, but it would go way up to the top. So a lot of times in citrullinemia, you're seeing elevations in 2,000 to 3,000 micromolar. All right. Now I'm going to switch. Now I'm going to switch to a urine sample. And this is really only applies to these anhydrine-based systems. But I wanted to go over this disorder a little bit. So this is a urine sample on a patient with arginosuccinic aciduria. And I'm going to use every bit of my high degrees and describe this as sort of a blob that comes out between 70 and 90 minutes. And this is all arginosuccinic acid and the anhydrides that are produced in this system. So typically ASA, at least what I've been taught, is that ASA is not reabsorbed well. And so it's excreted a little bit better. It's excreted, you're going to find higher quantities in the urine than in the plasma. And so the other difficulty in using these anhydrine-based systems is you get this very complex pattern, if you want to call it that. You can boil these samples and typically get one peak out of it. But if you're using a lab that uses an anhydrine-based system, this metabolite can be problematic. So let me then show you a plasma on this same patient. So when you look at a plasma on an ASA patient, typically you'll see this mild elevation in citrulline. This is probably about 100 to 120 micromolar. And then if you come over here to the right, what coelutes with leucine is this ASA coelutes with leucine. So you'll see this side peak, or sometimes in these systems, you can't separate them. And then you get these two little peaks here to the right that correspond to, at least in our system, homocysteine or homocysteine and GABA. So again, let me go back. That's all this. It's nice, big, easy peaks to see. But it can be a little more subtle in plasma. And well, when we talk about mass spectrometry, I want to come back to this. I have seen one, typically I don't worry much about these little peaks if I don't see an elevation in citrulline, but Pete's team, or the team here, does follow one patient who's homozygous for the mildest ASL mutation. And actually that patient had normal citrulline, but using mass spectrometry, they were able to pick up the ASA. So it's an outlier, but it's certainly a patient that taught me something. Okay. So we talk a lot in our field about mass spectrometry and how it works. And so I've tried in this version of this talk to put in a little bit more about the concepts of how mass analysis works. And so if you think of your blood sample as sort of like your pocket change or your big coin bank, what mass analysis allows you to do is take that mixture and separate that complex mixture and separate the coins or the molecules based on their size or weight. And that's in an essence what a mass spectrometer can do. It can take either whole molecules or fragments of molecules and can separate them based on what's called their mass to charge ratio or their size. So I just put that in here as sort of a primer, and we're going to talk a little bit more about mass spectrometry and tandem mass spectrometry. But I did want to acknowledge that there are faster methods, and I think you're seeing more and more labs switch to doing amino acids using tandem mass spectrometry. And this has a much shorter runtime. So again, I told you it would take over 2 hours to do. It would take 2 hours to do the anhydride-based systems. Tandem mass spectrometry allows you to get down 30 minutes or less. We're looking at a protocol that's about 18 minutes. The reason it can do this is we don't have to rely just on retention time to identify the individual molecules. We can use the mass or the fragments of different molecules, and we can actually have overlapping peaks, but the mass spectrometer doesn't see them that way. It is much more expensive. You're dedicating an instrument, well, not necessarily dedicating an instrument, but it's going to take a lot of instrument time. I want to get back to that ASA patient. So the nice thing about tandem mass spectrometry is you can separate a lot of times those peaks that co-elute in the classic systems, and you can so you can have a single individual peak just for ASA. And again, in our mild patient, even though the citrulline was normal and our anhydride-based system had trouble picking it up, the tandem mass spectrometry analysis was able to see a nice peak of arganosuccinic acid. So what I've heard, and this is to my wonderful colleague Marzia Pasquale, who's gone through this transition, that you do have to get used to the fact that some things you couldn't detect as well with the older systems, now you see. And so what is normal, you may see alloisoleucine in all your samples, but they may not be sufficient to cause concern. And certainly tandem mass is generally considered to be needed for anything you're doing in dry blood spots. So this is a lot to keep up with. What are some resources? You know, I love whether it's Dr. Soderbray's analysis or some of the other large textbooks that have these wonderful tables that talk about the individual amino acids and what diagnoses they're associated with. I I've tried to memorize these, but I certainly have these pages well worn in the copies that I have. To me, if you're a fellow, I would find these textbooks. I would print off 1 to 5 copies of these, and I just always have it with me. Laboratory and laboratory professionals are good at doing interpretations, but when you're there with the patient, I think it always helps for you guys to have all the information that you need. There's also this wonderful uh, um, it's also this wonderful laboratory technical standard, sorry, by the ACMG. And to be honest, if you're looking for a way to quickly study for the boards, I would use these documents. I think 90% of what you need to know are going to be in these technical standards. They're available for all 3 of the conditions that I'm going to talk about. So what I wanted to maybe have a little bit of discussion about, and just to allow me to have a drink of Coke, is I wondered if anybody else is getting an uptick in patients being referred for the smell of maple syrup. And this is one of the references that I go to about prenatal or postnatal fenugreek exposure. But I wondered if anybody else has other, or can put in the chat, other compounds that might lead to a baby being sweet smelling. So again, unmute, have at it, and I'm going to have a drink of Coke.
Hey, this is Jessie from Michigan. I get plenty of referrals for funky smelling urine, and not once has anyone told me that they have consumed fenugreek. It's very disappointing. But their labs are always unexciting.
Okay, well, that's good to share. That's been my experience. Kirsten, can you tell us a little bit more about IBCLC? I will have to look that one up.
It's a breastfeeding consultant. People
thank you.
who support moms through that journey.
Thank you. Sorry about that. Well, I think there's a whole fellow project in figuring this out. And I think it's a project about not only what the compounds are, but what's the false positive with this? Do these babies really smell? But it got me thinking about it, because we're working with a family right now who just swears, and the baby's doing fine. I think he's about a year old, but we get this referral a couple of times. So I'd love for you guys to talk a little bit more about this. This is the reference, but there are several that are out there. And again, if you can think of some other things that might lead to these sweet smelling babies, or the urine that's sweet smelling, we've done a wonderful job teaching our colleagues to look out for this. But I worry sometimes we're crying wolf a little too much.
Tim, I'd be curious if you could ask families that call in for this, and we could do this too, what brand of diaper they're using. I feel like there's certain diapers that have that smell in the filler, but I don't know exactly which brands do and don't. But at least we've observed that, and we haven't pinned it down to the exact type of diaper, but there are definitely diapers that have that smell.
Okay. Well, I hope everyone heard that. That's a good thing for me to know. When we think about the odor, one of the things I like about this paper and a related paper is that it talks about the component of what that smell is, and it talks a little bit about this, or one of the related papers explains how maple syrup and MSUD have this common metabolite. So for those of you that are foodies, that might be something that you're interested in.
Looks like Don saw the same thing and Katie saw the same thing too. So it's out there. I think we need to publish it.
Well, I'm conflicted because this brings samples into my lab, but obviously we don't need to stick babies when we don't have to. Okay, so let's keep going. Doing okay. Let's talk a little bit about organic acid analysis. It's kind of intimidating for me to talk about this because of Colorado's history with organic acid analysis, but I'll do what I can, and I appreciate the questions you guys have put in the chat. And I, again, encourage you, as we're talking about this, if you have pearls of wisdom or anything like that, please share with the group. So these are a lot of times intermediates in the degradation of amino acids, carbohydrates, and lipids. I enjoy rereading this slide because every once in a while I get asked about plasma organic analysis, and that remembering that these molecules are not reabsorbed in the kidney, and therefore urine really is the ideal specimen for the analysis. I know we used to do plasma here, but it was one of the things that we discouraged. Interesting discussion between quantitative organic acid analysis and qualitative. A lot of times for diagnosis, qualitative is generally sufficient, but I think as we get more and more interested in having numbers and exact values, and physicians clinical teams look for those values, that we're going to have to continue to move towards general quantitation. From the lab side, it is really difficult. It is a lot of work, because you really need standards and internal standards for a lot of what you do. If not, then you start using some surrogate markers, and then the quantitations aren't as precise. And again, I adapted this from NAMA. What is the clinical utility of having these precise quantitations? That's a great thing for you guys to discuss. Okay, so how do we do this? I think I forgot to put a title on this one. So the urine specimens are normalized to a fixed amount of creatinine. And what's nice about this is this allows all the analyses to look the same coming off the instrument. So you don't have to try to calculate in your head how dilute the urine might be. And I bet everybody knows, but creatinine is one of the standard ways we use to determine the dilution of the urine, how concentrated it is. The urine specimen is acidified to a pH of 1. We then use some organic solvents to extract the organic acids. We then remove the ether, typically with nitrogen, and then we derivatize with TMS for the detection, and I'll show you a little bit about that in a minute. So if you're new fellows and you're used to your classic clinical chemistry fast turnaround time test, just keep in mind that this process is very labor intensive, and it does take a while. So if it's 5 p.m. on a Friday, which is when everybody gets those stat calls, and you call your lab colleagues and you say, hey, can I get an organic acid done? Well, we're going to be in the lab until 9 or 10 o'clock that night. And I always appreciate Pete and the other colleagues here at Colorado who understand that. But it's one of the things I try to say when we talk about organic acids. Amino acids is a short prep, but a long time on the instrument if you're using anhydride-based systems. So just a quick comment. One of the other changes or methodologies that you can use is something called oximation. And this helps preserve the keto acids. You're adding hydroxylamine, because sometimes these short chain keto acids will not be derivatized. And so I think about pyruvic acid, alpha ketoglutarate, the branched chain keto acids, and succinylacetone. But maybe if there's some other compounds that people want to put in the chat or yell out that they really like with oximation. And when I moved to Colorado, they don't typically oximate here at my former institution. Every sample was oximated, and I had to get used to the big difference in doing these qualitative interpretations. So the method of analysis we're going to use once we've prepped that sample is gas chromatography mass spectrometry. So here's that mass spectrometer coming in again. We are going to separate them via gas chromatography. So for the anhydride-based systems, we use ion exchange chromatography. Now we're using gas chromatography. Once they come off the through the gas chromatograph or the column, they're hit with an electron beam that'll fragment the molecule. And so I want to spend just a minute talking a little bit about fragmentation. But the idea is that this collection of daughter ions, this fragmentation pattern, is like a fingerprint, and it allows you to identify the parent compound. So you might have two molecules that come off the column at the same time, but if they have different enough spectra, you can take a look at what they are. Now, I got trained on a nice long 45-minute run here in Colorado. We do an 18-minute run. I think it's easier to learn on the longer run because typically each peak is a single metabolite, but I'll let the chat blow up if I'm wrong on that. So the idea is that if your molecules are these puzzles, left and right, if you were to break those puzzles up and fragment them with a consistent amount of energy, that they will fragment the same way each time. And then you can measure the size or the mass of these fragments to get a very precise fingerprint. So that's kind of how this works. So let me show you what some of these look like. These are spectrums from various compounds, and these are taken from Dr. Goodman's book. So each of these lines represents an individual fragment, and the number attached to them is the mass over charge ratio, or generally for these, the mass of the individual fragments. So this is the pattern for lactic acid. Down here, you can see, although some of the ions are shared, here's 3-hydroxybutyric acid, here's methylmalonic acid, and here's tiglioglycine. So if you're really good, what you do is you memorize the characteristic ions of each one of these, and you can just look at the spectra and figure out what it is. And those are exceptionally bright people. But what a lot of times we do now is we attach a computer system to the GCMS system, and we ask the computer to try to match the profile that we're seeing in the patient sample with a known library, and then it'll give you a percent match. And there's sort of it's kind of convoluted how that works, but generally it's nice to use the computer to compare your patient sample with known standards if you can't remember all of these spectra. So keep in mind that similar compounds may have similar fragmentation patterns. So here's tiglioglycine, here's 3-methylcrotonoglycine. The structures, again, this is all from Dr. Goodman's book. And you can see that there's several ions that are shared, but we'll use the GCMS to separate these chromatographically. And then, for example, that 139 ion here at the bottom is going to be seen, or more abundant at least, in 3-methylcrotonoglycine and in tiglioglycine. I found that these patterns are very specific. So not only can you look at the mass, but you can look at the relative intensity of various ions to make your determination. But sometimes these can be very difficult to determine, and if you're going too fast, you might call one compound a closely related compound. I know when we have new techs, sometimes they'll flip these two. So this is what a normal organic acid will look like. This is still a pretty manual process for a lot of labs, maybe not all of them. And so we will print this off on a piece of paper. We'll do it in landscape, and we will start going through each of these peaks. So we would click on this peak. We would get this spectrum. We would see that that's a very good match for urea, and we would label it as urea. We would see this spectrum, and I'm sorry it's separated into two, but the lower half of the spectrum's on the bottom and the upper half's on the top. When I see citric, I look for this trifecta here, and then a 465. And then here's hippuric. So again, based on retention times, based on spectra, once you've done about 1,000 of these, you can kind of look at the printout and know pretty much what's there. Okay, so that's my primer. Now take a look at a patient sample. What do you see here? I see this nice big, and yeah, I guess I should write all this out. Sorry, MMA stands for methylmalonic acid. So a big peak of methylmalonic acid. So we would say that's pretty hard to miss. But down here, and what Tina Cowan taught me was down in the weeds, down in the lower section of the chromatogram, is this little compound right here called methyl citric. And so that would be very specific for the pattern of those two compounds would be very specific for methylmalonic acidemia. You sometimes see mild elevations in methylmalonic in B12 patients, but in patients that are B12 deficient, but you don't often see the methyl citric. And typically as the MMA goes up, the methyl citric will go up. Okay, so here's another one. Can you guys tell me anything about this one that looks funny? And C just means drug. And some of those things we're not exactly sure what they are. Okay. So this is a hard one. But what if I told you that, and I'm sorry for the line that goes across. So this patient is a 12-year-old who has recurrent fevers and has had a normal immunology workup. Okay. So the characteristic compound here is mevalonolactone, which tends to ionize a little bit better than mevalonic acid. And so, yes, Max, well done. This is a patient with mevalonate kinase, the milder version of, or who has a milder phenotype of mevalonic aciduria. And so the reason I bring this case up is just to point out that sometimes you got to have good communication with your lab. If I don't see that recurrent fevers in there, if you guys don't tell me that you look, it could be pretty easy to blow by some of these smaller peaks, especially for something sort of rare like mevalonolactone. So I always like, if we see this, we get it quantitated. I think we do it at Kennedy Krieger. And so the other nice thing is that a lot of times labs will set up specific assays, very sensitive quantitative assays for some of these rare metabolites that they're interested in. And you can phone a friend and figure out where to send various quantitative organic acid analyses. Okay, so compounds can be associated with an IEM or they cannot, and I sort of inferred about methylmalonic acid and B12 deficiency. I haven't seen methyl citric with malnutrition a lot, but it's in some of the textbooks. Every week I see a little bit of tiglioglycine and isovaleroglycine, and those patients are usually on seizure meds. This is a wonderful resource. It's again 22 years old. It would be great if it would have a refresh by one of the fellows. But going through and figuring out what are the organic acids on the left, what are the possible causes, and then what IEMs on the right. This is another one of those papers that I have on speed dial because I think it still works for a lot of different disorders. And then finally, again, going back to your ACMG standard and guideline, the other thing that I wanted to mention is if you haven't accessed, there's the human metabolome database. And so you can put in your you can put in your analyte of interest. Be careful about the spellings, but once you get it to come up, it's got a wonderful array of data, where it was seen, a general description, the pathways it's in, what various levels may be normal and abnormal, and then references as to what it's been found to be, what disease phenotypes it's been associated with. So again, these 3 references plus going back to Soderbergh or something like that are wonderful ways to learn about organic acid analysis. Okay. The next one to go over is azocarnitine analysis. And this introduces a instrument called a tandem mass spectrometer, where we put 2 of these mass analyzers next to one another. And I've tried to describe this different ways, and I'm not sure I've ever succeeded, but essentially you're creating 2 highly specific filters to not only identify your compound of interest, but to look at a fragment of that compound. And again, we've talked about how fragmentation patterns can be very specific and help with the identification of compounds. And what's so cool about this instrument and why it is so powerful, not only in our field, but in clinical chemistry, is how you can switch between molecules in a matter of milliseconds. So if you wanted to create a specific, I think about this, I was driving into work today, you can think about this as sort of like your fast lane. You can think about it as a beam that you're creating for those ions to go through, but you're taking your sample here that contains various compounds, and you're creating a very specific, again, lane for a single molecule to go through. So think about everything that's in your your blood, and you're trying to pick out that one molecule of interest. So a tandem mass spectrometer is just a really powerful instrument. It's revolutionized our field and lots of others. And the reason is by having those 2 mass filters next to each other, you can get high sensitivity, high specificity, and you can get it very fast. Okay, so if that explanation isn't good enough for you, here are a couple of different references. This is one that just came out in the Journal of Mass Spectrometry and Advances in the Clinical Lab. It's a history of triple quadrupole mass spectrometry. This is just, you can find this online. What is mass spectrometry? I get the feeling it was, I think it's taken from a talk that was done probably with some wine or beer at the end, but it's really a nice explanation. And I've used a couple of examples off this. If you're looking for a more clinical side, this is a nice article. And there's all kinds of wonderful YouTube videos and other things. So if I've tweaked your interest, take a look at it. The only other thing I'll do, and I won't show you this just for the interest of time, but these are 2 of the gentlemen that have been tallied with coming up with what is a tandem mass spectrometer. It's about a 10-minute video, but it takes them through this. It's the companion to the article that I showed you a little bit earlier. I always enjoy hearing about how discoveries were made, the serendipity, the collegiality, and this is just a great example of, for a tandem mass spectrometer, how this instrument got built and the revolution that it created. So again, you get a chance, it's about a 10-minute video, or even that article's not too long. So one of the reasons I like talking a little bit about serendipity is that's one of the ways I understand azocarnitine analysis came together, is they had a discovery of a patient with propionic acidemia with carnitine deficiency, and they suspected that these intermediates, these azocarnitines, might be the cause of that, carnitine deficiency. And then it just took off from there. When I was a fellow and was just getting trained, this azocarnitine analysis, the full spectrum of what it can do, was being announced at various meetings, and we were getting trained. It can be done using different methodologies, but tandem mass spectrometry is really the classical way to do this. it's important that a lot of times any pathway where there's a CoA compound might form an accumulation, and that's why not only do we see this in these intermediates of fatty acid oxidation, but also organic acidemias. You're probably all aware that this was around 20 years ago, was applied to dry blood spot analysis, and that allowed a vast expansion of newborn screening, including fatty acid oxidation and organic acidemias. This was one of the coolest parts of my training and my professional career, was to be part of this explosion that happened. You'll hear a lot of times it described as an analysis of what's called a parent of 85 scan, and I can tell you a little bit about how that works, but some people form butyl esters or methyl esters, but a lot of times these are actually done without derivatization now. One of the things to mention is that now when we look at these, instead of a time at the bottom, we're looking at mass at the bottom. So we're doing these analyses in 30 seconds, 2 minutes. We're doing them very fast, and we're combining a bunch of different scans. And so we set the second mass spectrometer, the second quadrupole, up to only allow fragments of 85 through, and we adjust the first mass spectrometer through the masses that would apply to different acylcarnitines. So the way this works is we add in some internal standards. These are acylcarnitines that have been modified to have a separate mass. It's what I call a stable isotope has been added to them. So they have a separate mass, but they retain all of their chemical characteristics. And for everything out, the same amount, the same relative intensity of all of these blue stars are shown, okay? So this is a normal acylcarnitine. Your propionyl carnitine is on your left, all the way up to C18, or your longer chains are on the right. Okay, so this is where I need a little bit of help from you guys. Again, short chains on the left, long chains on the right. Okay, what do you think this patient has? Starter compounds are all the internal standards. They're the same amounts put in, and then the spectrum itself is rescaled to the highest or most abundant ions. So you got short, you got medium, and you got long. So which ones are these? So you got elevations in C8, C10-1, and C6. And so this is MCAD. So this is what a patient with MCAD will look like. I love how visual this analysis is. The other thing I was going to say is if you ever get a chance to hear Dr. Millington speak, he's a wonderful speaker. He explains this really well, has taught me so much over the years, and it's really interesting to hear this story. Okay, so here's a patient with MCAD, right? That's pretty much what it'll look like. And I'll have an elevated C8 to C10 ratio. That's the other point I wanted to make, is that a lot of times we can use ratios of what's before the block to after the block to determine whether a patient is affected or not. Okay, what about this one? So you see the internal standards, the blue stars are some of the most abundant ions in the spectrum. And then you can see some ions here to C6, to C8, and to C10-1. So the same analytes we saw earlier. So the question is, does this patient have MCAD? And so this patient does have MCAD, but also has a low carnitine level. And so the point I'm trying to make is that remember that acylcarnitine profiles require a sufficient amount of substrate to form those acylcarnitines. And so if your patient is carnitine deficient, like Dr. Rowe and Millington's original patient, you can get spectrums that are or abundances that are suppressed. So I usually look at C0. Is there an abundant amount of that? Or if they don't report that, and not all labs do, you can use acetylcarnitine or C2 to determine whether there's enough free carnitine around. So what's important about this is, although this patient had low carnitine, if you were to look at the C8 to C10 ratio, it would still be high. Okay, here's the next one. Again, short, medium, and long. What do you think this patient has? So we've got elevations of C14, elevations of C16, trying to throw you off track here, C18-1. But then, whoa, you've got a hydroxylated species. Actually, 2 of them are elevated. And so this patient has, actually has LCHAD. And the reason I showed you that late, but the reason is because of those elevations in hydroxylated species. You see the elevations here of C14-1. It's not wrong. But typically, these hydroxylated species would push you more towards LCHAD. Okay, so this is a patient who came into the Children's Hospital here. She was fasted because of surgery, and I was able to get them to order a carnitine and an acyl-carnitine, and this is what her profile looked like after she had fasted for her surgery. And I can't tell you how long that was, but I would guess it would be overnight. Okay, now what do you think about this profile? This is actually the same patient after she's had a meal and is returned to the fed state. So again, mild elevations of C18. So this is her LCHAD at baseline. And it's just to point out that some of these long chain defects and have very normal looking acyl-carnitine profiles when they're unstressed and when they're fed. MCAD, some of the shorter chain defects, in my opinion, they're not as, that you don't have these sort of false negatives that you could have with some of the long chain defects. But this was very striking to me when I had them run this, and how you went from, all of these ions here in the background, all those accumulations. This. Okay. All right. So another thing we run into a lot is an acyl-carnitine profile in kids that are ketotic. So you do see some of these elevations of things we mentioned VLCAD before, C14-1, C18-1. But typically what I see is you also see an elevation here of C4OH, sometimes C2. And I really rely on my ratios here of C14-1 to C12-1. Typically, those ratios are going to be normal even in ketotic kids. Although I have called Pete in a panic one time because I had one of these that was a little bit over 3, and we repeated it, and I think Pete had a genome at that point, and it was okay. But just keep in mind, if you're focused very much on the long chains, don't forget to look sort of at the front of the profile and see if anything's getting through. What about this one? This will be the last one that I show you. So starred compounds are still all the same abundances, but now we have all of these various ions showing up. And they are things like, oops, I didn't put them all on here, but right, this would be MAD, taric acidemia type 2, riboflavin deficiency. I was all excited one time because I had a profile like this in a patient with autism, and I was going to define autism and riboflavin deficiency. But it was just a child who would only eat French fries, got very riboflavin deficient, and as soon as they gave him some riboflavin, he was okay. I will say my experience with especially later onset MAD or even riboflavin deficiency is it's not always this characteristic of elevations across the board. You can see episodic elevations in either medium or long chains often a lot of times. And I don't think I put it in here. But there's some nice new articles coming out about how patients on antidepressants, I just can't remember, uptake inhibitors, serotonin uptake inhibitors, I believe, in a small number of patients can give you a MAD type phenotype. I'm sorry I didn't put that reference in here, but that's something we've been working through, and there's some nice papers either out or just about out one from an Australian group, and then there's one coming out from a US group that talk about those serotonin reuptake inhibitors and how they can influence acylcarnitine profiles. Thank you, Pete. SSRI. That's what I was trying to say. So what can you get? You get a patient that's on MCT. You can see elevations in the medium chains, and this may make you think a little bit about MCAD, but typically the C10 is going to be higher than C8, so that ratio can get you, that ratio can help you out. Keep in mind that you can get elevations of C8 sometimes in patients with who are on valproic acid. And then I want to spend just a minute of time talking about pivalic acid, which can give you elevations in C5. And this wasn't a problem as long ago, but we've seen some papers come out recently that pivalic acid compounds are making a comeback. Here are some of those references. And so if you get an elevation of C5, and especially on newborn screening, you might think about not only antibiotics, but these pivalate containing creams here in the US. So these are a couple of articles you might want to take a look at. One of my favorite papers is this one, the laboratory analysis of acylcarnitines, a technical standard written by lots of famous people. And this is a summary table, and I use this table all the time to help remind me which acylcarnitine is associated with which condition. Also a really nice supplementary table that gives you the specific masses for each of your compounds, for each of your acylcarnitines. So if you're interested in this, if you're interested in more of the mass analysis, it's really helpful when you're setting up the protocols. So just to give you guys give me a time to take another drink. Can you either put in the chat or say what other conditions you can use acylcarnitine analysis for? Okay, right. I guess I should be, so we think about acylcarnitine analysis with fatty acid oxidation disorders and organic acidemias. But now we're seeing papers that use acylcarnitine analysis or elevations in acylcarnitines to broaden the perspective of what we can use this test to determine. Yep. Jamaican vomiting sickness, mitochondrial disorders. Thank you. That's one of the ones I was thinking of. What else? There's one other one I wanted to highlight. So, right, so some peroxisomal disorders was where I was going. There's some really nice papers talking about long chain, so even taking acylcarnitines out beyond C18, and I believe it's C3 dicarb or malonyl-carnitine that was in one of those papers. But please, let's not limit this analysis to just fatty acid oxidation disorders. One of our postdocs, Dr. DeAnnabelle, who's now at Cincinnati Children's, did some nice work on some markers of ECHS1 that might be able to be detected on an acylcarnitine profile. So I think we need to keep looking at these profiles very specifically and see what else we can find. But thank you guys for your input. Okay, so the last thing I wanted to spend a little bit of time talking about was functional analysis. And I'm going to use an example for lysosomal disorders, but this really applies because I think as we do more next generation sequencing, we are going to have to come up with more functional assays, either to express variants or just to determine the pathogenesis of variants. And so I want to throw an idea out there of that we could use mass spectrometry to do that. So enzyme analysis is going to be more complex. You may need to use cultured fibroblasts. You're going to have to typically get live cells, which are leukocytes, out of blood. Keep in mind that as soon as you take the blood sample, those cells start to die. And if that sample is more than 48 hours in processing, it's going to be hard to pull the leukocytes out. We're not typically testing the blood. We're pulling the leukocytes out, and we need them hopefully to be still alive, but certainly not lysed. And what happens is, as that blood's in transit, either from the physical motion of transport or just from being out of the body, and then some of the harsh chemicals in the blood tubes, they start to lyse. I know 3 to 5 mils of blood is a lot. Some people are going to ask for 10, which is really limiting in small babies. But please keep in mind, it's really important for that blood to get to the lab as soon as possible. So how do we do this? Well, typically we take the patient sample here, which provides the endogenous enzyme, and we mix it with some sort of substrate. So from my experience, one of the most common artificial substrates to use has something called 4-MU or 4-methyl umbelliferol on it. And that 4-MU is fluorogenic in a basic environment. And so you design the substrate such that the endogenous enzyme cleaves the 4-MU off. And when you put that in pH of above 10, you get fluorescence. And so you're reading out the fluorescence as a marker of enzyme activity. If your patient lacks the endogenous, or your sample lacks the endogenous activity, the 4-MU substrate stays bound, the 4-MU stays bound, and there's essentially no, or maybe just a very little bit of fluorescence. And so this is the way a lot of these lysosomal enzymes work for MPS 1, MPS 2, MPS 6, and so forth. There's variations on that theme. But the other really cool thing that was led by Mike Gelb's group and those at Genzyme and other places was that actually what we could do is go back to our friend, the tandem mass spectrometer, and we could put in a substrate. And we could, instead of looking for fluorescence or radioactivity, we could just look for the substrate going to the product, and we could detect that by tandem mass spectrometry. Again, a very specific filter, in this case, for our product. And this is the basis of a lot of newborn screening for LSDs. You can use fluorogenic substrates, and there's nothing wrong with using it. But because the tandem mass spectrometer can bounce between molecules very fast, this technology is a little bit better for multiplexing in a single sample, because all the 4-MU assays will have the same readout as released 4-MU. So I encourage you to think about this. If you've got your condition and you want to design an enzyme assay, think about using tandem mass spectrometry to create your specific filter for your specific product, so that you could design your own enzyme assay. So when we do these enzyme activities like we do for analytes, we get a range of activity, and we want to always define what the normal range is. And what we hope is that that's very different from the affected range. And what we're finding, though, as we get into this, and especially with next generation sequencing, as we do more with, we identify more carriers, we identify more what I would call hypomorphic alleles. Actually, this may be our normal range, but we really need to better define what our carrier range is. How does that overlap? And is there any overlap between the carrier range and the affected range? And it's down here where the red line and the yellow line meet, which gets really frustrating for clinicians, right? This is the area where we want to have good separation. And for some assays we do, and for some assays we don't. And that's why I think one of the challenges in our field is we need to stop worrying so much about the normal range, and we need to really focus on this area down here and redesigning our assays so that they can answer those clinical questions. So the soapbox that I get on for this, can you have false positive enzyme results? Let's think a little bit about what we're doing. What we're doing is we're saying, I put all these chemicals in a tube, I put my patient samples in a tube, And if I see fluorescence, I know that it's normal. And if I don't see fluorescence, ooh, maybe the patient is affected. Well, if you think about that process, there are all kinds of reasons why you could get no signal from a reaction. If you were challenged in doing your chemistry reactions like I was, you got more negative reactions than positive reactions. So keep in mind that human error, technical error, all those kind of things lead to a false positive result more than say, hey, if you have a grossly elevated phenylalanine, that's going to be less of a technical problem, maybe a sample switch. So typically a second enzyme or some sort of control enzyme should be used, and these are typically done in duplicate or triplicate. Also keep in mind that for some disorders, things like lysosomal disorders, there are causes for an enzyme to be deficient outside of the gene that we typically think of. So a patient comes in for low MPS2 enzyme activity. A rare number of those cases will actually have multiple sulfatase deficiency if your IDS sequencing is normal. On the flip side, there's targeting defects like mucolipidosis 2 and 3 that can have low activity in fibroblasts, can actually have elevated activity in plasma because those lysosomal enzymes aren't making it to the lysosomes and they're being shunted outside the cell. What I really wanted to get to, and I'm glad this year I have a little time to talk about it, is this concept called pseudodeficiency. And this is an enzyme activity that's deficient or close to abnormal in phenotypically normal individuals. And so we're running into this a lot as we do newborn screening for lysosomal disorders. I'd encourage you to look at George Thomas's paper from 1994, which is one of the first sort of summaries of how this worked. His example was, or his definition was, that enzyme values are sufficiently below the carrier range that carriers of these pseudodeficiency alleles are confused with or indistinguishable from affected patients. Metachromatic leukodystrophy has a very common pseudodeficiency allele, and so they give a little bit different, definition, and then the one of the family support groups has an even further, slightly different definition. So what I wanted to say on my soapbox is that there's the laboratory definition of pseudodeficiency and there's the clinical definition of pseudodeficiency. There's how you talk to this phenomenon about patients, and there's what we say in the lab. And in my opinion, it's just my opinion, we're trying to use the same term to describe those two very different scenarios. So for example, you might in the laboratory side call these a hypomorph because that's really what happens. So how many disorders have pseudodeficiency? I would argue it's probably more have them than don't. And if we find a gene that doesn't have one, it's probably just because we haven't expressed enough variants. I've highlighted some of the main ones here. One of the other common misconceptions is that this phenomenon is associated with just a problem between the artificial substrates, those 4-MU molecules, and the real substrates. And that's generally not the case. Generally, there is some biological phenomenon that goes along with these. You can have reduced messenger RNA expression. You can have changes in glycosylation. You can have variants that reduce the stability, or you can actually just have a enzyme level that goes down but doesn't cause the pathology associated with the disease. And as you read about these, you'll find that some of these are complex alleles that actually combine these various mechanisms into one allele. So again, it's coming back to these technical standards, but this is a really nice table that Christina Kuzmano put together of sort of what the known pseudodeficiency alleles were, what the variant is, and what the effect is on enzyme as we knew it 3 years ago when we wrote this paper. You can look up either one of any of these variants, and there may be newer information out there. And again, this is not an exhaustive list. If you're interested in this phenomenon at all, there is a ClinGen work group that I'm excited to be part of. It's led by Jennifer Goldstein and Lauren Clark. Sorry, I did this slide at the last minute. Looks like I gotta some formatting differences there, but I talked to both Jennifer and Lauren, and if you have any interest in working on pseudodeficiency, please email them and they'll get you involved in the group. At the moment, we're trying to expand what we did for the ACMG guideline and really get a nice full list. The other thing that I would argue is that pseudodeficiency alleles aren't just lysosomal. How about our Duarte allele? How about the newborn screening variants we see for IVD and MCAD? Again, if you think about the phenomenon as just reduced enzyme activity that doesn't cause disease, you really can see that in a lot of different genetic conditions or a lot of different inborn errors. So I am pretty much out of time. I did want to put in here some other uses of LCMS to do acylglycines. We already talked a little bit about X-linked adrenoleukodystrophy. All the cool stuff that's going on with GAGs and glycosaminoglycan analysis in both urine, blood, CSF, and dry blood spots. Looking at specific assays, some of the classic metabolites that we've used, things like ion exchange chromatography for, like sulfocysteine. And it just goes on from there. It's why this talk's a little bit hard to do because there's so many different avenues we could go. In just 2 slides or a couple of slides to go, I wanted you to remember that while diagnostically BGL may not be as central as it used to be, there are some really cool advances that are going on and really things that are changing individuals or individual fields or multiple fields. Things like the work that Mayo did in terms of dry blood spot GAGs, or their identification or development of a biomarker and then moving that biomarker for what they did for cytosine. The really cool stuff that's going on at Baylor with global maps and metabolomics. I'll give a shout out to my colleague Johan van Hove and some of the work that he's doing on mitochondrial proteomics. If you haven't talked to Johan about this, it's really exciting stuff. And then just sort of a general multi-omics approach. How can biochemical genetics be integrated in? So what I would argue is that while, yes, we're not in that classical number 2 testing position in diagnostics where we used to be, where we were one of the main testing, we have all kinds of exciting stuff in our field that we can do to help with patient care and improve patient care. So I think there was something put in the chat about what I would call the threat to our field, and that is the increasing regulation that's coming from the FDA regulation of laboratory developed tests, or some revised form of what's called the VALID Act, which is going through Congress. Just keep in mind that I believe all, if not the vast majority, of BGL tests are what are called laboratory developed tests. And in the past, these for the FDA said, well, good, you do that, but we're not going to really regulate those. And now the FDA has said they're going to regulate them as a medical device. And this is going to put a huge strain on our field unless we can get some carve-outs, and there are lots of people working on this. But whether you're a clinician or a laboratorian, this is something you want to keep your pulse on, because in the next 4 years, unless there's major changes, this is going to significantly impact, especially test development and probably test offering in our field. And again, my understanding is there really are none of our tests that are, other than maybe some of the newborn screening stuff, and I don't know that for sure, but certainly some of the diagnostic tests don't have, there are no FDA approved kits out there. So I talked about this, clinical trials, biomarkers. I said this a couple of weeks ago at a meeting, and I'll say it again. When you think about your precision medicine programs and what's trying to be done in there, I really think inborn errors of metabolism, BGL type stuff, what they're trying to do in precision medicine, we've been doing for 20 or 30 years. And so get in there. educate your colleagues on the cool work that we do in biochemical genetics, how we have identified disorders, developed treatment, and I've identified patients prior to their presenting. PKU is a great example. I'm still always amazed that we just sort of talk about another case of MCAD as if it's this random thing, and that's a child that had a severe health risk before we got involved. The last thing is, as you're moving on in your field, as you're thinking about new tests, make sure that the assay is designed for and can answer your clinical question, okay? Don't try to take an assay that's designed for diagnostic and try to make sure and just assume that it can also work at the very specific levels between, say, carrier and pseudodeficiency. Okay, so this is our group. Thanks to all these guys. Thanks to you guys for listening. Thanks to everybody who's taught me over the years. I will stop sharing and maybe take 1 or 2 questions.
Awesome. Thank you, Dr. Wood. That was great review of some of the most common things that you run across in a biochemical laboratory. You and I were having this conversation a couple of days ago. I still think there's a ton of value in diagnostics too, given turnaround time and depending on your institution and what kind of molecular you're able to order and how fast it'll come back. So especially in the neonatal period, newborn screening, lots and lots of opportunity for diagnostics there. So ton of value. Questions or comments for Dr. Wood? I agree. Jesse, totally agree.
I'll give that a thumbs up.
Being able to run a diagnosis down or a sample down to the lab and then a diagnosis up from the laboratory within hours. It's really nice.
If I have one parting shot I can give you guys, it's that please make sure you contact your labs. Labs work sometimes in a bubble. They're not always aware of what's going on clinically. And generally, these are people that are very patient focused. They want to know what's going on. They want to provide help. And it may take a little work, but send them an email, get them on the phone, because again, a lot of the colleagues I have love to learn and work and know that they're helping patients.
Thank you, Tim. Last chance for questions for Dr. Wood. Had a lot of good comments in the chat, a lot of agreement. All right. Well, thank you all. Thank you, Dr. Wood, again for the great presentation. And everybody have a good weekend. Tune in next week for Dr. Steiner and lipids. It's a great lecture. So thanks all. Bye-bye.